Case number 5, you see the touch of urothelium, but they are invading into nests in the subepithelium. This is the denuded normal urothelium here. So this is a invasive high-grade urothelial carcinoma. Here you can see the muscle invasion. This is muscularis propria. This is very, very important because once the muscle is involved, muscularis propria is involved, they will go for cystectomy. That's why pathologists play a very important role to say whether muscle is present or not in a biopsy. And when it is present, we have to say whether tumor is invading into the muscle. And when you don't see muscle, you please mention it in the report. It's a papillary urothelial carcinoma, high grade. Muscle bundles are not seen in this biopsy. And this is again invasion. Here it is the traditional urothelial carcinoma, whereas here you can see clear cell urothelial carcinoma, which we will be seeing in a minute. And as I told you, invasion is very, very important. And invasion into the lamina propria or invasion into the muscularis propria is very, very important. And the invading epithelium will have irregularly shaped nests, or there may be single cell infiltration, or irregular or absent basement membrane, or finger-like projections going into the lamina propria and muscularis propria. And the invasive cells will have high nuclear grade and they will have more juicy eosinophilic cytoplasm. So it is morphologically different when compared to overlying carcinoma in situ. And whenever there is invasion, stroma also will respond by showing desmoplasia or sclerosis, or it can show retraction artifact, lot of lymphocytes, because lymphocytes are the policemen of our body. And whenever there is invasion, they just respond to that abnormality. And the stroma will become myxoid. Sometimes the stroma becomes pseudosarcomatous, or surprisingly in some patients, there may be no stromal response. Coming to the subtypes of urothelial carcinoma, it will be urothelial carcinoma with squamous differentiation. Please remember, this is not squamous cell carcinoma. There it is urothelial carcinoma with squamous differentiation, glandular differentiation, trophoblastic differentiation, nested urothelial carcinoma, tubular and microcystic urothelial carcinoma, and micropapillary urothelial carcinoma. Other than tubular and microcystic urothelial carcinoma, all are having very bad prognosis. We don't know exactly the prognosis of this tubular and microcystic urothelial carcinoma. But one thing you have to remember, stage determines the prognosis. In the stage, histological type determines the prognosis. That you have to understand. So you have to compare stage by stage. You should not compare stage 1 nested urothelial carcinoma with stage 4 tubular and microcystic urothelial carcinoma. I hope you understand what I am trying to say. Stage is very, very important. In a given stage, histopathological type and grade comes into help us in the prognosis. Lymphoepithelioma like urothelial carcinoma, plasmacytoid urothelial carcinoma, giant cell urothelial carcinoma, lipid-rich urothelial carcinoma, clear cell or glycogen-rich urothelial carcinoma, sarcomatoid urothelial carcinoma, and urothelial carcinoma that is poorly differentiated. The lymphoepithelioma like urothelial carcinoma have a better prognosis. The prognosis of glycogen-rich urothelial carcinoma we don't know, whereas all the others are having very bad prognosis. We will see pictures of them one by one. So this is a urothelial carcinoma with squamous differentiation. And as I told you, you have to mention what is the component composition of squamous cell and urothelial carcinoma in these cases. You can see nice keratinization and attempted epithelial pearl formation. So this is urothelial carcinoma with glandular differentiation. And you can see nice cribriforming nuclear atypia and the invasiveness. So this is a glandular differentiation. This is urothelial carcinoma with the trophoblastic differentiation. You can see the syncytial trophoblast and cytotrophoblasts in this tumor. This is a nested variant. Nested variant is a special type in urothelial carcinoma, where you can see small nests of very bland looking cells going very deep into the muscle layer. And if you go to the high power, they may look like a bland, very benign urothelial cells. And they are all arranged in a nested pattern. Sometimes they may resemble paraganglioma. And but when you do markers, the neuroendocrine markers will be negative. And this nested carcinoma, even they look very bland because of the deep infiltration, they behave very badly. It's one of the poor prognostic types. And this is a carcinoma. You can see the urothelium in the top. Here there are some tubules and some gland formations with the dilated glands with the eosinophilic secretions. So that's why it is called tubular and microcystic urothelial subtype of carcinoma. And when you do cytokeratin 7, you can highlight all the tubular and microcystic component. Micropapillary carcinoma, you can see small papillary processes without any fibrovascular core. That's why they are called micropapillary. And they will have retraction, classic retraction artifact. They may look like a lymphovascular invasion, but these are all retraction artifacts, and these are seen invading into the muscularis propria. And they have a very poor prognosis because the lymph node metastasis is very high in micropapillary carcinoma, not only in bladder. And whenever you see micropapillary carcinoma in any organ, the prognosis is bad because of the lymphovascular invasion and lymph node metastasis. This is a carcinoma in the low power. It looks like inflammatory. Medium power, you can see some pink cells. In high power, you can see nice tumor cells. So these are lymphoepithelioma like carcinoma. They may look like thymoma also, type B thymoma. Okay. So why this is important, and whenever you see a lot of lymphoid cell infiltrating in any tumor, you have to look for PD-1 and PD-L1. That means here the tumor cells are friendly with the lymphoid cells. This many lymphoid cells should destroy the tumor cells. But these tumor cells have very friendly relationship with the lymphocytes because of the PD-1 and PD-L1. So anti-PD-1, PD-L1 will help in these tumors. For targeted therapy with anti-PD-1, PD-L1, we have to keep it in mind in all the tumors with heavy lymphocytic infiltration. Here, this is the overlying urothelium. It shows some carcinoma in situ, very atypical cells. And in the subepithelium, you can see infiltrating tumor cells that looks like plasma cells. See, they are looking exactly like plasma cells. So these are plasmacytoid urothelial carcinoma, plasmacytoid differentiation. Here the cytokeratin 7 and 20 will be positive because sometimes this may be mistaken for multiple myeloma or lymphoma. But CK720 will help you to differentiate from hematolymphoid neoplasms. This carcinoma shows a lot of giant cells. So this is a giant cell differentiation, urothelial carcinoma with a giant cell differentiation, bad prognosis. This is lipid-rich carcinoma. Whenever you see clear cytoplasm, three things can happen. There may be accumulation of water, there may be accumulation of lipid, or there may be accumulation of glycogen. So when it is positive for Sudan black, it is lipid rich. And again, this is having a bad prognosis. Whereas here we saw that in the conventional urothelial carcinoma, this is the conventional type. Here it is clear type. Why I am calling glycogen rich? This is PAS positive, PASD negative. So this is why it is, that's why it is called as glycogen rich, clear cell. And this is a sarcomatoid carcinoma. It's very difficult to tell this is carcinoma. This looks like sarcoma. But when you do markers, the epithelial components will be positive. So this is a sarcomatoid carcinoma. Those are all the subtypes of urothelial carcinoma you have to know. So coming to case number 6, it's slightly out of syllabus. Here you can see a lot of tumor necrosis and tumor cells, and these tumor cells are very small and they are having crush artifact. And whenever you see dark blue cells with a lot of crush artifact, you have to think of small cell carcinoma. And small cell carcinoma is a neuroendocrine carcinoma. Previously in WHO classification, they used to include neuroendocrine, mesenchymal, melanocytic in the main classification of tumors, but now they have different chapters of neuroendocrine tumors, different chapters on mesenchymal tumors. They are not coming under the WHO classification of any organ. That's why when you think of the presentation I did for WHO 2022 classification scheme, I never talked about neuroendocrine, mesenchymal, hematolymphoid, melanocytic lesions. So this is a small cell carcinoma, and they will be positive for synaptophysin and chromogranin. And GATA3 is another good marker for neuroendocrine tumors, but GATA3 will be positive in urothelial carcinoma also. And another neuroendocrine marker is INSM1. I forgot to mention that here. Insulinoma-like protein, and that is positive in neuroendocrine tumor. So don't believe only on beta-3 because it will be positive in neuroendocrine as well as urothelial carcinomas. Case number 7, you can see the nice urothelium. Suddenly it becomes glandular, and they are lined by tall columnar cells with some basal cells there. And the lumen have some crystalloid structures, secretions, eosinophilic secretions. So these are cystic spaces, and they are lined by columnar type of epithelium. And this is a classic example of cystitis glandularis. Classic example of cystitis glandularis. And when you talk about cystitis glandularis, there are 3 members in this diagnostic group. When you see the lining epithelium predominantly urothelial type, then we call cystitis cystica, no columnar epithelium. And when you see solid, these are one Brandt's nest. Okay. And when they have cystic degeneration, then it is cystitis cystica, urothelial lining epithelium. When you saw tall columnar cell epithelium, then it is cystitis cystica glandularis. And in that tall columnar cells, when you start looking into the goblet cells, then it is cystitis cystica intestinalis. So you have to have the criteria lined up very nicely. When do you call cystitis? Sorry. When do you call cystitis cystica? When there is urothelial lining epithelium. When do you call cystitis cystica glandularis? When there is columnar epithelium. And when you see goblet cells, we call it cystitis cystica intestinalis. Case number 8, you see the urothelium and a lot of lymphoid infiltrate, and this looks like granulomas, and these are granulomas. And when you see granulomas with a lot of lymphoplasmacytic infiltrate in the bladder, you have to ask for history of BCG. Remember, we talked about intravesicular BCG, and that produces granulomatous reaction. If there is no history of BCG installation, this is more like follicular cystitis and granulomatous cystitis. But when the history is there, it is BCG related changes. So history is very, very important. And I saw this case, very interesting. These are hepatocytes, and they had granulomas. They are negative for no other lesions for TB. TB is the first one you have to think when you see mild portal inflammation and portal-based granulomas. But this patient never had any history of TB, but there was a history of intravesicular BCG treatment, and they presented it as a case, and I thought it's very interesting. This is the first time I saw when I was looking into the literature last week. So this is a BCG granuloma in liver. Case number 9, it's a 76-year-old male underwent TURP, But this is more incidental finding. You see the urothelial lining epithelium, a lot of cystic spaces, papillary processes, tubules. And when you see these hobnailing and other thing, you have to think of nephrogenic metaplasia. Why they call nephrogenic? They think these are all the nephron cells or proximal tubular cells. They come in the urine and settle in the bladder or urethra, or there may be metaplastic change of the urothelium into nephrogenic lineage. And when you see it in high power, you can nicely see hobnailing, small cystic spaces, large cystic spaces, papillary processes. And you all know PAX8 is the marker for nephron cells, proximal convoluted tubules. And these cells are positive for PAX8. So this is nephrogenic metaplasia. Previously, they used to call nephrogenic adenoma, but now they are telling molecularly it is not a neoplasm. It is more like reactive or metaplastic change. In this case, lot of eosinophilic cells, and lot of lymphocytes, and a few plasma cells, few scattered eosinophils. And in the high power view, you see a lot of inclusions in the cytoplasm, targetoid inclusions, what we call Michaelis-Guttman bodies. And so this is a case of malakoplakia. When you do calcium stain, vancosa, they will be very nicely positive in malakoplakia. And this is more like a spindle cells, and this history is very, very important. Okay. Otherwise, a lot of differential diagnosis will come. And whenever you see spindle cell proliferation with scattered inflammatory cells and small capillary type of blood vessels, you ask for history of any previous bladder procedures. And this patient had a previous history of bladder procedure. So this is post-operative spindle cell nodule. And they may look like inflammatory myofibroblastic tumor, and some of them can be positive for ALK protein also. So these are myofibroblastic cells with extravasated RBCs and scattered inflammatory cells. Remember, inflammatory myofibroblastoma in the bladder, ask for history. When there is a history, it is not IMF, it is post-operative spindle cell nodule.